Thank you, Bob, Marianne. Good to be back in NCAN. Thank you, everybody, for sticking around. It's not easy. It's the end of the day. Hats off to you all. Thank you so much. My name is Aman Chauhan. I'm a medical oncologist, and I lead our neuroendocrine cancer program at the University of Miami. Another hat I wear at the University of Miami is I co-direct our theranostics program. We'll talk a little bit about that today and learn about what theranostics is. It's intertwined with PRRT. Now, throughout today, you've heard how neuroendocrine cancer incidence is increasing, the burden of this disease is increasing. We actually have over 170,000 patients with the diagnosis of neuroendocrine cancer in the United States. Okay, so it's no longer rare, by the way. Okay, it's quite prevalent. Unfortunately, because our patients live longer, and they are living even longer as compared to historical past. Okay, and because of this growing burden of disease, we realized we need to do better. We need to find better treatments. I was just having a chat with a participant, an audience earlier. There was a time 10 years back, we hardly had any treatment options. We had it was one pony trick, sandostatin, and that's it. If a patient progressed on it, increase the dose of sandostatin, right? And when it came time to do PRRT, we used to send patients to Europe to get PRRT. I remember those times. I was a resident with Dr. Voltring and Dr. Wang and Dr. Boudreau's clinic at LSU. The times have completely changed since then. Fast forward to now. I personally at University of Miami, in last 2 years, we have set up a busy neuroendocrine cancer program. We have catered to patients from 30 different states, 10 different countries in a short span of 2 years. And that's the reason is because of newer drugs that we have developed, newer clinical trials, access to newer drugs. So in front of you, what you've seen is the progress that neuroendocrine cancer community has made in last decade. Not one, but several drugs. Last month, we had cabozantinib, got FDA approval. So every year, we are making progress. We have our colleagues from Crinetics here. They are developing a fantastic pill version of somatostatin analog. I presented the data at NANIS last year. Successful phase 2 study that is going to now go into a phase 3. So again, not only cancer drugs or radiation-based drugs or chemo drugs or TKIs, we are making overall progress. Even in somatostatin analogs, we are trying to develop pill versions and alternatives to monthly injectables, right? But for today's talk, I will focus on lutetium-177 dotatate or PRRT, okay? That's the, what do you call it? The hottest topic in the town, okay? And the reason is because this field called theranostics, it's already grown out to be a multi-billion-dollar industry in last few years, and it's expected to be over $30+ billion industry in a decade to come. And the two flagship drugs for theranostics right now in the United States is a neuroendocrine tumor drug called lutetium-177 dotatate, Lutathera. Another one is Pluvicto, a prostate cancer drug. But wait, in next few years, you will see drugs which are radiopharmaceutical based, helping treat breast cancer, colon cancer, pancreatic cancer, all sort of solid tumors. So this is just the beginning of a revolutionary field of anti-cancer treatments, right? So what is theranostics? It's a concept where we use diagnostics and therapy, and we have sandwiched it together called theragnostic or theranostics, okay? So what is diagnostic? We do a PET scan. If the tumor has the target, we detect it on the PET scan. And if the PET scan lights up, we know it's a tumor, has the target, we give the therapy drug. So it's a very accurate way to know whether the drug will work or not because we can see the target. It's not like biopsy where we do biopsy and we then assume, okay, if the target's present in that sample, it will be present everywhere. Here you get to see the whole the patient's disease burden and whether they have target or not. So that's the concept. Let me explain this concept now with neuroendocrine tumor. So think of neuroendocrine tumors like LOC. These tumors have somatostatin receptors. That's why neuroendocrine tumor is so unique. It has somatostatin receptors. Think of the tumor or receptor like a lock. We have a key. What does key do? Key goes and joins the lock, right? So the key is sandostatin, lanreotide, or the Crinetics drug, the paltusotine. These are somatostatin analog. Analog binds to the receptor, like key binds to the lock, right? So that's exciting. What if we make this key radioactive? Copper 64, gallium 68. These are radionuclides, okay? Radioactive heavy metals. What if we coat this key with radioactivity and then inject it? Then what happens when we inject this stuff? It goes in your blood, it finds wherever the tumors are, attaches to the tumor. And since it's radioactive, it will emit radiation. You do a scan and you can see the tumors. This is how you're able to see tumors on your dotatate PET, because these are radioactive keys. All right. And if the tumors light up, you know you have receptors. Then what you need to do? You just switch this radionuclide from gallium 68 or copper 64 to our heavy duty lutetium 177. Because now we don't want to detect them. We want to burn them, kill them, right? So it's emitting more radiation. So this concept is called theranostics. You change the receptor, make it a breast cancer receptor, HER2, you have a breast cancer drug. You make it PSMA, the receptor, the target in prostate cancer, you make it a prostate cancer drug. So that's why a lot of excitement in this field. You can develop a lot of drugs. But I'm proud to say, as a neuroendocrine oncologist, Lutathera or lutetium 177 dotatate sort of really revolutionized it. I mean, we were the front runner, okay? Now, let's focus on, we discussed a little bit about how this works. As you can see on your screen, lutetium 177 dotatate, the lutetium 177 is that radioactive moiety attached to dotatate. That is the key, the somatostatin analog. And when you inject it, it attaches to the receptor, that somatostatin receptor. Once it lands on the receptors, you see it's sitting on the surface of the tumor, the receptor. It then gets internalized, and inside the cell, it emits the radiation. That radiation is causing the DNA damage. Okay, that's how these tumors die. Nobody can survive without viable DNA. Okay, so you can see that radiation, the ionizing radiation, the beta radiation. That's why you've heard about alpha and beta. We'll talk a little bit about it. But what is alpha? Alpha is a type of ionizing radiation. The lutetium emits beta ionizing radiation. Okay, so these are different forms of radiations, different forms. So this is how the drug works. Now, theory is good. Does it really work? Well, Europeans were smarter. They knew it worked and they've been using it. But in the US, for what's it worth, for good or bad, I think for good, we like to see the data. Okay? So a large study was done called NETR-1. Half of the patient got lutetium 177 dotatate, other half got higher dose of sandostatin. And guess what happened? Patients who received lutetium 177 dotatate, those are the green line on the top, median PFS, versus the line on the bottom, 29 months versus 8 months. Doesn't get any clearer than that. Most of the cancer trials, minimal difference. Here, you can drive a truck between these two lines, right? That shows how effective these type of drugs are. And this was the landmark study led to FDA approval of lutetium 177 dotatate in the US. We no longer had to send patients to Europe. And since 2018, there are over 200 places in the US alone where this drug can be given. So great. Not only it is so effective in treating the tumor, keeping it stable, but this is one of those unique cancer drug that is also it jives so well with the quality of life. So when I meet my patients, I tell them, my job is to keep you alive longer, but with good quality of life, not at the cost of quality of life. So this is one of those rare drugs where patients who got lutetium 177 dotatate reported better quality of life as compared to control arm. So that's a win-win scenario for us. Fast forward to 2025, as I told you, we are continuing to make progress. So far, we only had one drug since the NETTER-1. Earlier this year, actually last month at eNets, Dr. Capdevila revealed the results of ITM COMPETE study. So we have another PRRT agent which have shown that it is very effective. In their study, 23.9 months versus 14 months. The control arm was more stronger in there. It was Afinitor, everolimus, as you know. So a positive study, and the company is going to file for approval. We will see what the FDA says, but the study is definitely positive. And for us in the field, the more the merrier. I have more options, better for our patients. So we are not just stuck with one medication, just in case what if something happened to that company, we now may have other alternatives. So that's a big positive step in our field. So let's get back to right now the only FDA approved agent is lutetium-177 dotatate. So let's talk a little bit about that. So it's very easy. It's 4 doses only. Each dose is given every 2 months, 4 IV infusions. So unlike some of our other cancers, it's not a weekly infusion. You don't have to take pills daily. You know, there is some ease to this. Those 4 infusion days, however, might be a little bit, you spend almost half a day with us as a long infusion, and you have to take radiation precautions. So I'm not saying it's a cakewalk, but as compared to other cancer drugs, this is still relatively easy and limited dose. Next few slides, I'm going to walk over how and when do you treat or recommend this type of treatment. The short answer is anybody who has metastatic neuroendocrine tumors, which is somatostatin receptor positive, that means positive on dotatate PET. That is an absolute must. If you don't have receptor, this drug does not work, as we learned, right? So somatostatin receptor positive metastatic disease who have progressed on prior lines of therapy. Usually it's somatostatin analog. So very frequently we are using this class of drug as a second line go-to option. In past, when we didn't have this, we would use everolimus and sometimes maybe Captem or chemo. Now we have a very good effective treatment that we often fall back on for a lot of our patients as a second line. So shots, then PRRT. Again, it's not as simple. Each patient we have to tailor it but for by and large, this is a good second line option. But if life were only as easy, right? And that's where the gray areas comes, and Dr. Maluchios of the world, no, I can resect, or the Dr. Andrews, no, I can embolize, and somebody would say I can do a transplant. So again, and they're all right, because every patient has a unique journey. Every patient needs a custom-made plan for their disease, okay? So my talk is just about the medicine aspect. So please, I won't be talking about surgeries, embolizations, and ablations and other things, okay? So if a patient has widespread bony metastatic disease, we do a dotatate PET, there's a lot of disease on the bone. That's a good candidate for PRRT because it goes to all those smaller and bigger tumors throughout the body. It's easy and it's very effective for bone mets, okay? As I mentioned, patients who have progressed on prior somatostatin analog, second line, third line is a fair, treatment. The metastatic disease, liver involvement, lymph node involvement, etc. There was a study that was done and reported last year called NETTER-2, where patients got frontline management with lutetium-177 dotatate. That means these patients had not even progressed on shots. They started their journey with lutetium-177 dotatate, and it was a absolutely positive study. However, those are more aggressive variety of neuroendocrine tumor, the higher grade 2 and grade 3 NETs. So those are the patients which are little fast-moving disease, and we don't want to give them shots. We want to treat them more aggressively because they have very aggressive cancer. So Lutathera was tried in the frontline setting and was reported to be very effective. So it's not unfair. It is a completely fair thing to do to start the journey with lutetium-177 dotatate with metastatic higher grade neuroendocrine tumor disease, okay? This is an example. It's a patient of mine. As you can see on right side, that's how the dotatate PET look. All those tiny dark black spots, those are tumors. There's probably not a single bone left in the body where you don't see a tumor, right? It's a young guy actually. and he was in a lot of pain. I had him on dilaudid every 4 hours. Bone mets can cause a lot of pain, right? 4 doses of Lutathera later, 64% reduction in the tumor volume. And what does that mean to patient? Came off from the dilaudid. Actually went back to work. So these drugs are definitely effective, okay? And so that's the kind of things we see with theranostics treatment. Last but not the least, when we are dealing with neuroendocrine tumors, some patients have what we call functional neuroendocrine tumors. That means their tumors are secreting hormones. Carcinoid syndrome patients is serotonin. VIPoma patients is VIP. Insulinoma patients insulin. So all sort of hormones, right? Fortunately, that's a rare situation, or not rare, but a smaller subset of patients, 20 to 30%. But those who do have functional tumors, it's not only important for us to treat the disease, but also to control the syndrome. And one way to control the syndrome is shrink the disease. Our traditional therapies, like sandostatin, lanreotide, Afinitor, all these treatments are cytostatic. That means they keep the disease in check, static, but they're not able to shrink the tumors. It's very rare I see shrinkage with injections. They keep it check, in balance. The very few drugs that are able to shrink the tumor, PRRT is one of those very few drugs. Kiptem for pancreatic nets, another one of those. And cabozantinib is a recent addition, is another one of those. But we don't have a lot of our traditional treatment are cytostatic. So when you need shrinkage, PRRT could be one of the options that we can consider. Now, what are some gray zone areas where it's not 100%? So if somebody has liver dominant disease only in the liver, and that too in one segment of liver, then certainly I'm not going to use my big gun and radiation treatment, because you cannot keep doing it over and over again. So I might save it for later and use embolization. You heard a good talk about embolization. So we use all the tools in our toolkit, or we may send the patient to surgeon and they can resect that, okay? So that's usually a possibility that we may not need to do it. Mesenteric disease. Some patient has a lot of tumor around the small bowel. The mesentery is a tissue around the small bowel, holds the bowel together. And when you have a lot of mesenteric disease, there's concern of bowel obstruction, because Lutathera is a radiation-based treatment. When you radiate the tumor, they are dying, they get swollen, it's causing inflammation. And if it's around the bowel, you might get obstructed. So a lot of net centers, including ours, we prescribe sometime a short course of steroid to reduce that inflammation. It's not mandatory for everybody, but this is for high burden disease in the mesentery that we do that, okay? So you got to be a little conservative there. And of course, if patient has bone marrow issues, one of the side effects of lutetium-177 dotatate is it's a radiation-based treatment. No matter how accurate it is in going to the tumor, it does expose other parts of your body to radiation. So some patients may have some decline in the blood count. It does bounce back. But a patient who has been on chemotherapy for a long period of time prior to PRRT, they may have some exaggerated blood count issues, okay? So if your bone marrow has already taken a lot of beating from a lot of other anti-cancer drugs in the past, you are at risk for those bone marrow-related issues. So you got to be very careful. So the patients who I treat with lutetium-177 dotatate, they have good, healthy bone marrows. So if you have a platelet count of 40, that's not the patient I'm going to recommend lutetium-177 dotatate, okay? And then low volume disease. Somebody has a very tiny volume disease. They're going to my surgeon. Hey, listen, take it out, reset the clock. We buy some time. We use our big guns when the disease is really spread out and the surgeons can't help, or IR doctors can't help. And what are some of the important contraindications? Of course, if you're pregnant, this is not the drug for you. It's radioactive, it's teratogenic, so of course not. Low blood counts, thrombocytopenia. If you don't have targets, if we do a dotatate PET and it's not lighting up, then this is not the drug for you. Fortunately, most of our GI net patients, that's not a case, but some lung net patients, they don't have somatostatin receptors, so that can be a problem. Kidney problems. Now, I've treated close to 400 patients with Lutathera in my career, and I've not seen a single case where patient ended up on dialysis with this drug, okay? So it's relatively very safe. However, the problem is if the kidneys are poor to begin with, there are patients who unfortunately suffer through diabetes, high blood pressure, all sort of kidney problems. I have a cutoff. I would usually refrain from treating somebody who has GFR less than 40, or they need to know if this is the only option that you might end up in dialysis. So we got to be ready with that, okay? All right. Last segment is about clinical trials. Of course, there are a lot of exciting trials happening in our field, and that's what motivates me and keeps me going. However, I cannot cover everything. I'll touch up on few things which are interesting to me with the help of a case. Okay. Now, this is a 68-year-old female, history of breast cancer, was treated 20 years back. Breast oncologists have done a great job with the outcomes of breast cancers, cured from that standpoint. Unfortunately diagnosed with pancreatic neuroendocrine tumor during routine surveillance in 2014. Was doing fine. She was just getting a routine scan and then was picked this. Ultrasound confirmed a mass in the tail of pancreas, some lymph nodes, no lymph nodes were enlarged. They did a biopsy during the endoscopy and it confirmed to be a neuroendocrine tumor. Now, these are the days when dotatate PET was not very prevalent. They did the old school Octrio scan. These days, nobody should get that. Everybody get a dotatate PET, much clearer. And the scan was negative for cancer spreading. So luckily, we caught it early in the tail of pancreas. This is how it looks. That's the tail of pancreas there in the arrow. And there was no tumor elsewhere. So what we have learned from Dr. Meluccio, surgery is a fantastic tool, especially when we are dealing with early stage neuroendocrine tumor. So this is a patient that needs to go get the surgery, okay? And did get the surgery. As we know, surgery for early stage is standard of care. You will not get surgery only if you're not a surgical candidate. There's some sort of contraindication or a patient preference for some reason. And we have data to show you. This is a publication. I was part of AJCC neuroendocrine tumor guidelines, and we published the outcomes. I show this to all my patients, new patients I see in the clinic. You see, this is pancreatic neuroendocrine tumor 5-year survival. The top 3 lines are stage 1, 2, and 3. At 5 years, 90 to 95% patients are disease-free. That's an amazing amount of statistics. Very few cancer patients can say that for their respective cancers. So for early stage neuroendocrine tumor, large patients would be still cancer-free at 5 years with surgery. Metastatic disease is a different ball game, right? So that's why we say, when it's stage 4, we cannot cure you, but our patients with newer treatments, PRRT, SSA, all sorts of stuff, our outcomes are still very good. Almost 60% of our patients are alive at 5 years from diagnosis. This is probably 10 or 15% for a regular pancreatic cancer, right? So our patients do a lot better when it comes to outcomes. All right, so moving forward, patient got surgery, did fine, had a good 4 years. Unfortunately, in 2018, one of the surveillance scans showed liver mets. The cancer back, and there's a lot of liver mets peppered throughout the liver. So let's presume patient was not a surgical candidate because of the amount of disease. What would we do next? What does the group think here? Any votes? What's our first go-to treatment? The shots, right? Good. You guys all get honorary doctorate. So that's what we did. And it's standard of care. It's nothing new. We've known this now for 20 years based on 2 very important studies. The sandostatin was approved based on PROMID study, lanreotide approved based on clarinet studies, and both the studies showed the somatostatin analog slows the cancer down. That's why we love it. It is very benign. It's not a toxic chemo. It's not a radiation. And most patients, I won't say all patients, but most patients tolerate it very well. And we love it, okay? So that's how we started. Patient did really well, okay? And from 2018 to 2022, did fine. So we got 4 years of stability with just the monthly injections. Unfortunately, now the cancer progressed. This is the dotatate PET in 2022, and this was markedly worse than as compared to the last 4 years. But these tumors are lighting up on dotatate PET. What does that mean? They have somatostatin receptors, right? And this is maybe I'm giving you cues that what would we do next, right? I wish my teachers were like that. I would pass easily, right? So we did a PRRT-based treatment, and this is just a couple of months earlier. I saw the patient for a routine follow-up. Look at the scan before and after, right? Of course, not everybody would be like that, but I have to show you good examples, right? I have to be politician here, right? But, the drug works for sure, right? And this is an excellent response. And of course, we did lutetium-177 dotatate under a research protocol. And that's why I wanted to showcase this example. This is not just the lutetium-177 dotatate. This patient also took certain pills along with it. So that would be a segue into what are some of the trials that are happening. Now, lutetium-177 dotatate was a pivotal shift. It was a very impressive drug that was FDA approved 2018. Should we just stop there? Are we happy with 28, 29 months median PFS? Or should we try to push the limits, make it even better? I would want it to make it better, right? We now want to make these drugs twice as good, more safer, right? So how would we do that? With research, newer generation of treatments. So one of the ways to do is find newer drugs, right? One of the newer drug is alpha PRRT. There are alpha, it's the same concept. They target somatostatin receptors, but the radionuclide is either actinium-232 or lead-212. These are heavy metals. So they are emitting alpha ionizing radiation. And the early data from phase 1 studies is looking very impressive. In fact, we have a patient here who just recently had alpha-based PRRT and is showing good shrinkage. So that's one of the pros of alpha PRRT is high energy. And we are, at least the early data, showing very good disease shrinkage. What is unknown, and we are eagerly awaiting, is the long-term data. Are patients living longer? Is the disease also controlled longer? And last but not the least, is it safe? Are we seeing kidney safety, bone marrow safety? And there are 2 studies that are investigating these type of agents right now, and it looks very promising so far. The other strategy is that, hey, we have this winning drug, lutetium-177 dotatate. How to make it better? So add something to it. That's the strategy I've personally taken, although I'm also participating in alpha PRRT studies. But this is a homegrown research right from my fellowship days in the lab, that I was combining different drugs in the petri dishes, in the animal models. And we have found some success. I'll share some data with you. So one of my earliest study that was funded by you guys, this is an NCI-sponsored study. So taxpayers are funding this study, okay? And it's based out of our work that we did in the lab, and we combined a drug called triapine. It's a ribonuclide reductase inhibitor. What does it do? So as I told you, lutetium-177 dotatate, it attacks the cancer by destroying the DNA. Then why does the cancer survive? Why does it come back? Cancer is also trying to fight us. It is repairing its DNA. That's how eventually the tumor grows back. So the concept was, what if we give lutetium-177 dotatate, destroy the DNA, and give something along with that to block the repair process? Made sense. And this triapine drug does that. It blocks the repair process. So we treated about 30 patients in 6 cancer centers. This is University of Kentucky, Ohio State University, Utah Huntsman Cancer Center, Northwestern in Chicago. So all reputable cancer centers, okay? 31 patients total. You're probably the first one to know, and we haven't published this data. This is literally fresh as of last week. And this, since it's not an actual medical symposium, it doesn't count. So I can tell you a secret. The median PFS is 39 months. You remember I told the Lutathera, 29 months? We just added a pill, a small pill that patients take for 2 weeks for 4 times with their Lutathera. And that's the difference. That's pure science for you, okay? So the phase 1 is done. This phase 1 led to a randomized phase 2. So a larger phase 2 is currently enrolling in 14 cancer centers, including MD Anderson, you name it, all big name cancer centers. The study is actually almost done. We wanted to enroll 94 patients now. I think we're almost at 90. So any day now the study will close. And then we will wait and see if we confirm our phase 1 data into phase 2. And if that turns out to be true, then we will do the final and most important study called phase 3. And if that is positive, then everybody can get this drug. That's why it's not for the faint-hearted. You have to spend years for the drug development. I've half my hair white. That's going to be when I started. But it's all worth it. If it works, it's all worth it. Okay? So far you are seeing promising results and studies are progressing through, and we'll see what the time is. Another combination we are testing is a DNA PK inhibitor. It's a drug that was made in Germany by German Merck called M3840. Now it has a name called peposertib. This study is also now completed and we are awaiting the data. We will see how that looks, okay? So we are testing different combination with lutetium 176 dotatate and hopefully something sticks. Some of my friends, Dr. Del Rivero, they are testing another combination with a PARP inhibitor called olaparib. Another friend of mine, Dr. In Seattle, Dr. Hagen is testing cabozantinib combination. So different physician scientists are testing their own combination, and all power to them. More choices we have, better it is for our field, okay? All right, so I leave it to the last segment of the talk, hypothetical. Now, this patient got treated when 2022, 25 scans look beautiful. Let's suppose this is 2027. Another couple of years have gone by. Unfortunately, now the patient has progressed. What will we do next? Well, remember this was the patient. So far, so good. But add 2 more years to it. And now patient slowly progressing. What will we do? And these are the options. Actually, all these options are accurate. That's how much progress we have made. We have more and more options each year. But, yes, looks like somebody has drunk the PRRT Kool-Aid with me. So, re-challenging with PRRT. Now, see, of course, it's obvious. If I was the patient, hey, doc, give me the stuff that you gave me and got me like several years of stability disease, right? It's obvious. The problem is right now, FDA have only approved lutetium 176 dotatate for 4 doses, 1 time. So any extra use is off-label, depending on your insurance, will they cover it? Because we don't have safety data from a prospective study. So what are we doing? There are 2 important studies. One is Raise Bio Action 1 study, okay? And it's a very, very important study. It is testing an alpha PRRT agent in patients who have already progressed on standard of care PRRT. Very promising study. And if it turns out to be positive, will lead to hopefully another drug for this indication. But this study is currently enrolling in a lot of centers throughout the US, including University of Miami. So an important study for consideration. The other study is, what about our good old Lutathera? So we designed a government-funded study. It's a joint US and Canada effort. I don't know if it's still called Canada, maybe another 51 state of US. So US joint effort. No, I'm kidding. So a good friend of mine, Dr. Simran Singh from Canada, is the PI from there, and I'm the US PI. And the study design is simple. As you can see, patients who've got Lutathera did well, at least a year of stable disease, and then now progressing. We will give 2 doses of Lutathera, all funded through the protocol, so we don't have to even ask the insurance to pay for it. And if this study is successful, we will be able to show that lutetium dotatate can be safely retreated. Okay, so this is again a very important study. We called it net retreat study. I came with that name, right? You like it? All right, cool. So this I think is an important study for our patients, and hopefully we can enroll. With that, I think we are out of time. Thank you so much for your attention, and it was a pleasure to be here. Thank you, Marianne, NCAN family, and all of you guys. Thank you.